My name is Brianna O'Connor, and here with me today is Dave Eckert, and we are going to be talking today about case conceptualization and treatment planning in practice. So this is the session where we're going to walk through a case example using the material from the previous two webinars where we reviewed case conceptualization and treatment planning. Just as a reminder, a couple of our company slides. So this is a presentation put together for the MCTAC, the Managed Care Technical Assistance Center, which is made up of the McSilver Institute and Casa Columbia. There are also several partners for MCTAC, including CCSI, which is where Dave and I are from. What we're going to be covering today are a few things. So first, for those of you who are on the previous two webinars, were able to make it or were able to watch the recordings, we're going to respond to the questions and comments that came in from some of those webinars. We are also, since there are a couple of us here today navigating, we're happy to take any questions or comments you have live in the chat box over to the right, and we can respond to those for you. We are hoping to have a bit of a discussion if people are interested today, so rather than just having us speak and present to you, if there are at any point any comments you have, or if you want to ask questions, or if we ask questions that you'd like to respond to, please feel free to chat in the comment box. I think if you raise your hand, we might also be able to figure out how to get you unmuted. But if we'd really like to have a discussion-based presentation today if you guys are interested. So what we'll be covering today, we're going to very briefly review the components of effective case conceptualization from before so that we can set up how to talk about a case example using that 5 Ps framework. We will also, again, very briefly review effective treatment planning in an effort to set up how to consider those appropriate treatment goals for the specific case example. And then we'll talk about a couple of key points of communication with the managed care organizations that might come up from a case such as this one. For those of you who got all of the emails, so today's talk is going to be specifically looking at a case that's more appropriate for OMH, and then at 1 o'clock we're doing this same type of webinar for a case that's more OASAS specific, and we'll have one of our teammates from Casa Columbia helping us to present that one. You're obviously more than welcome to attend both, but we just want to make sure you're at the right one. A couple of questions that came up before that were sent in for us is, especially referring to the case conceptualization, we had talked about making sure that one of the things the managed care organization wants to know is what happened before for this individual when they sought care, why were the previous services not successful, and where do you get that information? So in our conversations with the managed care organization, it seems that you as the provider, as the therapist, as the person linking with the individual seeking services, it's sort of up to you to figure out and to talk about in your history gathering what the person's previous treatment care pattern has looked like, and ask the individual what was successful, what wasn't successful in those environments. Some of that information may be in the referral documentation for you to refer to, but it's unlikely that you'll get the rich type of response about what worked, what didn't work, just from the referral documentation. It's about that give and take with the individual to find out those pieces of information.
And the second question that came up was related to treatment plan adherence and tracking, and it speaks to what training is required for our utilization management specialist liaison. So the intent of this question is, what if you have a non-clinical person linking with your managed care organizations to assist you with utilization management? And that's a great question, because that's probably going to be a common practice for some agencies for these questions to either come into billing or medical records or some combination of that for people that track the services directly. And those individuals would really need to know how to translate clinical documentation. So they would have to have enough clinical knowledge to know where in the clinical documentation to look to answer the managed care questions. There are key data points that they're going to need to know how to relate back the relevant treatment plan information. So what points of the assessment are they referring to? What points of the treatment plan are they referring to? And what elements in progress notes do they need to refer back to ask utilization management kind of questions, like how is this individual progressing? Why would we approve, or why are you requesting 4 more visits, and why would we approve that? Common questions like that. These conversations about approvals for further services, the goal is to have, if it's done by a paraprofessional, to make sure that they have enough clinical knowledge and understand enough about clinical documentation and have a clinical person as a backup to refer to answer these managed care questions and to be able to speak clearly to questions about service utilization and further service approvals. So that's a great question, and it's kind of a combined role, and training would certainly be required for that.
Thanks. That last question, someone had asked about, is this particular approach to case conceptualization or this particular approach to the treatment goals, are those the ones that MCOs are suggesting? And the answer is no. There are no specific structures that have been suggested or put out by managed care organizations. What we did is we, combed through the literature, had some conversations with the managed care organization individuals who are responsible for utilization management, and asked them what they were looking for, and kind of found good examples of approaches that really would give you the information that you need to report back and would also be in line with good, effective clinical practice. So these aren't required methods or processes, but they are ones that should line up pretty well with what most managed care organizations want to see. So again, if you have any other questions or comments as we go along, please chat them to us. And with that, we will just get started. Again, as a very brief review, when we talk about effective case conceptualization, we're thinking about that process where a therapist and a client work collaboratively to first describe and then explain the issue the client presents using theory. The primary function of case conceptualization is to guide treatment in order to relieve client distress and build client resilience. So a lot of that definition is about the client. What does the client need to reduce their distress, enhance their resilience, and how do we put the pieces together in a way that we can collaboratively come up with what's the issue, how do we treat it well. The method that we talked about before, the references are down below if you're interested in reading more about them, is the 5 Ps. Again, I like it because it's an easy to remember mnemonic, but those 5 Ps are presenting problems, predisposing factors, precipitating factors, perpetuating factors, and protective or positive factors. Here on the screen is just a brief reminder of what each of those are, but they are also sort of, it's in the name what we're looking for. And we're going to go through a case example now and talk about, and kind of pull out those individual pieces from this case. So the case that we're going to talk about today is Manuela. She's a 24-year-old female of Latina heritage. She's been referred from a routine visit for a psychiatric assessment because she expressed some symptoms. She is a former dance instructor and international dance performer, but right now she's reporting migraines and symptoms of depression that have been going on for approximately the last 2 months. Those symptoms include not wanting to get out of bed, not eating, not sleeping at night, but then feeling kind of sleepy during the day, losing interest in a lot of things, wearing kind of the same clothes for several days, having a little bit of difficulty with personal hygiene, and she is having some suicidal thoughts. In the past, she has saved some over-the-counter medicine, a pain medication, just in case, as she reports it, but she's afraid to use them to complete suicide because she's afraid that it would have physical consequences that would make her dancing career no longer viable. Recently, that was a little while ago, recently she reports that she's bought some more pills and she's counting them weekly but does not take them. When asked if she would complete that act, she's not sure if she would act on those suicidal thoughts. So that's the initial presenting concern from this individual. And here, one of our first 5 Ps, we can see a couple of presenting problems are already apparent. There's some symptoms of depression, some suicidality, and there's an unemployment piece that might be causing her some distress in her personal life. Asking a few more questions of Manuela about her history. She's not from the United States. English is her second language. She grew up in a family that was working class, and her father moved between two families. She's the only girl, has a lot of siblings. She feels like when she was a child, she was favored with a lot of attention, that her family focused on her being very attractive and was very musically gifted, and she really liked to perform. She did do well in school, but had some somatic symptoms of headaches and stomach aches, and she found it kind of hard to concentrate in areas that she didn't enjoy, although she did tend to try her best. She reports that she was happy as being on stage. She'd been dancing for a while, but would get really excited beforehand, could not sleep in anticipation of the performance. When she was 14, she did win a scholarship to a prestigious dance studio and began participating in competitions. Here, thinking about those 5 Ps, we can see a couple potentially predisposing factors. And again, a reminder that a lot of factors can fit in multiple Ps, and so this is just sort of our impressions here, and there could definitely be some overlap across the various factors. But here are some predisposing factors that I would highlight are, again, there's a history of symptoms, so she's been experiencing these symptoms for a long period of time since she was younger. There was some family stress when she was growing up. She's been reinforced for her looks and her talents. And with the national, international competition, she's clearly in a high-pressure environment. Learning more about Manuela, we find out that she says that she often did very well during the routine, but immediately afterwards would have episodes of extreme emotional distress, crying, feeling faint or nauseous, and reaching out and hitting either the walls or her dance partners to, as she puts it, let it all out. She reports that this was out of frustration, not with any force, and generally people forgave her because she has the soul of an artist. And those few people who didn't forgive her for these outbursts were jealous and unappreciative and didn't really understand her. Starting around age 16, Manuela started to develop romantic relationships, but she reports that they were often within the dance community, and they were fleeting and often very emotionally draining. Here again might be a few predisposing factors to make note of. There's a history of mood instability and impaired relationships, relationships where there's a lot of difficulty and that don't function as well and as positively as we would hope for her. And again, that mood instability here is going back to when she's maybe a teenager. Moving forward, we find out that Manuela came to the U.S. at around age 21 to be an instructor. She got a position in a very well-known studio. Her goal is to have her own studio in the future, but she was pretty happy in this job. She thought that she worked harder than other people. She didn't need as much sleep. She lived on black coffee and dark chocolate. But she was popular with her students. Her students really loved her, especially she would throw all-night dance marathons if the mood struck her, and they seemed to like that. Unfortunately, after about a year here, Manuela had a breakdown and was hospitalized for exhaustion. Through this process, they referred her for additional treatment and assessment, but she refused, saying that therapy is for crazy people, so that wasn't something that interested her. Here we can see a few different factors. So there's some protective and positive factors in here. She got positive feedback in her career, and a career that she really loved. She seems like a fairly independent woman to be able to move away from her family by herself successfully. And she's been successful in her career so far. There's also some potentially perpetuating factors here. She's in a job that has a lot of high stress, again. And when offered the link to services to facilitate some further care, she did refuse. So that's potentially a factor that would maintain her symptoms and her difficulties. After taking 3 weeks off following this breakdown, Manuela went back to teaching and felt pretty in control and very happy when she was in the studio teaching her students. She feels that she occasionally was displaying the emotionality that she displayed in her teens, but thought that it really only happened at certain times of the month. When asked about additional substances, Manuela reports that she does like to drink champagne, but doesn't use any other alcohol or substances, and she really only drinks because she likes the taste of champagne, so she drinks recreationally and never to excess by her report. Again, several factors of note here. A precipitating factor of potentially a biological impact if those hormonal influences on her mood are a consistent pattern. And again, some protective and positive factors She is involved in a successful career that she's happy doing and that she likes. And I guess a protective factor, or on the flip side, not a concerning factor, is that her alcohol use is typical and recreational and not something that she reports using as a coping mechanism. Leading up to near where we are now, when she's come into our office, are some incidents that have caused her fairy tale to be punctured. About 6 months ago, the wife of her studio's owner learned that Manuela had been having an affair with her husband. Also discovered that Manuela had used his credit cards to buy herself some very expensive costumes for her dance competitions. Following this incident, Manuela stayed home most of her time. She's been feeling very tearful, very distraught, and also feeling kind of physically ill. She lost that job following the incident, but she hasn't since then, in the past 6 months, hasn't tried to find a source of income, noting that she's been too distraught to do so. And around this time, she did learn that her older brother was moving to the city. He did reach out to speak with her, try to see her and get in touch, but she's been too upset to see him. Here we see some precipitating factors that might have immediately preceded some of her symptoms. The end of a relationship that she was having with the husband, her studio owner, and also the loss of a job. Again, before that seemed like a really high point for her and something that she was pretty proud of and did well in, and so losing that job would certainly constitute a pretty significant stressor. There are a few perpetuating factors to think about here. Unemployment as a factor, again, that can maintain some of those distressful feelings for her, again, especially because it was a job that she liked so much. There's a potential threat of legal issues from the husband and the wife regarding the credit card use, which can also serve as a stressor and cause her some further symptoms. But there is also the positive factor that she has a supportive family member who's around and in town and trying to reach out. So now we get to her current functioning following all of that history. So this is about a month later, which is now when she's in our office. In a moment of desperation, she had reached out to the studio owner and was very upset to learn that he didn't want anything to do with her despite their history. She does feel that if she was able to talk to her brother, things might improve for her, she might feel better. She's concerned because she feels like she's gone from a somebody to a nobody. And she has thought about running away and starting over, but is afraid that other people will find her and expose her, and that her former friends, now they want to see her suffer. Again, her current functioning, her suicidality, and symptoms, as we described before, are also concerning. Again, another precipitating factor here, that negative interaction with her former significant other could have been, again, a trigger, a stressor, an immediate precursor to some of her current symptoms. So that, I'm going to turn it over to Dave to put it all together and give us some treatment plan goals for Manuela.
Thank you. So now moving to put it all together, I think it's important to just refer back a minute to the purpose of case conceptualization. And there's an old saying in therapy that if you can name it, you can tame it. And getting a sense of what's going on with the assessment process, doing that together, really getting a mutual understanding of what's happening, finishing that in the analysis and formulation in the assessment, and then getting into the treatment planning process, that mutual contract about what you're going to do about it, really shines a light down the path of therapy, and certainly in and of itself has a very calming therapeutic effect. So let's talk about the diagnosis itself. Based on this information, we're leaning toward a major depressive episode, which is clear based on the symptomatology, time durations, et cetera. But we also have evidence that would cause us to want to rule out bipolar II disorder. So as we know diagnostically, it's not always a perfect process. We don't begin with very clean information that hands us a perfect diagnosis. Much of the time, it's a process of collecting information, working collaboratively, and honing that diagnosis. So we're going to talk about that process and doing that with Manuela. So in our discussion, related to this diagnostic impression here, the bipolar disorder is certainly a consideration. The evidence of that was mentioned of the all-night dance marathons, the impulsive buying, sleep and appetite disturbance, certainly key symptoms to pay attention to. The nature, though, of the trigger of the current depressive episode needs to be considered, though. As Manuela reported, the loss of that significant relationship triggered the current symptoms of major depressive episodes. So we have something that is a clear triggering event, and that's not always present when we have a bipolar disorder, which is more biologically driven and not so episode related. It's also noted that past episodes of elevated mood were situational. Again, we see these environmental triggers that need to be paid attention to. So further exploration is needed to make any kind of bipolar diagnosis definitively. Just as an aside, I think when it comes to bipolar diagnosis in particular, we want to make sure we're being trauma-informed and we're gathering all the evidence, because obviously the treatment for that is very different than the treatment of a major depressive episode. And we really want to get these clear indications of patterns and history so that we see those clear biological markers that are unmistakable, especially for manic episodes when we're treating bipolar disorder. In addition, we want to proceed with some caution because we have the long-standing and pervasive struggles with emotional regulation that date back to her childhood, and that whole soul of the artist emotional reactivity that she had reported. So we also have clear attachment issues with male figures, her father going back and forth between two households. So attachment needs, in particular with male figures, need to be taken into consideration as well. So we're projecting forward. We're going to continue this conversation with Manuela and put it all together here. Now, let's say she presented at a PROS program. What we want to do is check to see, well, we're going to see if she meets the criteria for this PROS program. And to be eligible for PROS, a person must be 18 years of age or older, have a designated mental illness diagnosis, and again, we're going with major depressive disorder, ruling out bipolar disorder, so check there. Have a functional disability due to severity and duration of mental illness, and we can see that the lack of employment, the social functioning, and even the legal entanglements or potential legal entanglements all are significant barriers to be paid attention to and seem directly related to the symptoms she's experiencing. So we can check that one as well. So all three of those criteria are met. She would then need to be recommended for admission by a licensed practitioner of the healing arts. Pre-admission begins with that initial visit and ends when the initial service plan, the ISR, is submitted to the Managed Care Organization or the HARP provider. So once that is approved, we have 60 days to develop that treatment plan with her prior to the admission date. So again, this speaks to the process of defining that path with her, continued conceptualization, and really defining what the plan for treatment will be. Active rehabilitation begins when this recovery plan is approved by the Managed Care or HARP organization. So the point of this slide is that, yes, we do have these criteria being met, and we could certainly work with Manuela to access her and engage her in PROS treatment. Getting back to the analysis and formulation, the end of the assessment, bringing those 5 Ps of case conceptualization into more clear focus here. What we've done with the case-related information, with the history we've gained from Manuela, is kind of projected forward. So what would happen in our continued work with her? We're taking some liberties to extrapolate on that and to decide, okay, what could reasonably happen as she engages in treatment, and how do we continue to assess, conceptualize, and move into treatment planning. So with the presenting problems, our procedure would be obtain the demographic information and background information needed to address safety and risk needs, get a sense of the acuity and chronicity of the symptoms of the depression. So that careful history taking is very important here. We also want to establish that previous baseline level of functioning. We know the duration, we're getting a sense of that. How about pre-symptom? How was she functioning prior to that? What we get from our findings there through our discussion with Manuela, she's a 24-year-old single Latina female, English as a second language, lives alone, former dance instructor, performer, favored child, father shuffled between two families, and has the soul of an artist. So you can see some of these things showing up in an assessment to capture in a person-centered way who Manuela is. We also have clear symptoms of depression, possible history of manic episodes. Again, we're going to want to rule that out moving forward. We have the stockpiling over-the-counter medications. We obviously need to pay attention to that. We'd want to use an evidence-based tool like the Columbia Suicide Severity Rating Scale to get that completed to assess for risk of harm to self. We really want an evidence-based approach and safety first, of course. Let's get a sense of the level of severity of those suicidal concerns. Let's say the results showed that she's not currently suicidal, though of course this needs to be closely monitored in future sessions. We want to begin to ensure safety and work with her on that. Analysis and formulation continued and getting into the predisposing factors. So we're delving into more detail here about how we're conceptualizing. The procedure we'd use, we'd want to adopt a trauma-informed what happened to you approach versus what's wrong with you. We really want to know from Manuela what triggered this, what happened, and how we go about phrasing our questions and how we have sensitivity to both our approach with Manuela and the clinical environment itself. We really want to encourage her to be forthcoming as we're non-judgmental, working on her behalf and assessing for trauma and the cumulative impact of the stress in her life. We want to gain a clear understanding of the duration and history of the symptoms, including information from key collaterals, if at all possible. Consult with physicians and medical specialists to rule out possible medical causes. We had the hormonal influence referenced before. We'd really want to get a sense of that. And of course, we'd want to complete a mental status exam and know where she is at baseline in the assessment process. Now again, moving forward and leaning into our findings here. So let's say Manuela denies a history of physical or sexual abuse, but reports that her relationship with her father likely impacted her ability to trust men and form healthy relationships. So out of the assessment conversation comes her own insight into attachments and her relationships with male figures. We also note significant variability in her mood and that the level of activity seems environmentally versus biologically triggered. It definitely seems to come from a reaction to events in her life. Versus more out of the blue or innately triggered. We also note the lifelong struggle with emotional regulation, but again, we don't have a history of self-harming behavior which we'd want to assess for if we were looking at symptoms related to borderline personality disorder. We have a medical history and the blood work that show no sign of any obvious medical condition to pursue further. So for the time being, we've got a clean bill of health regarding any medical concerns, and the mental status exam is consistent with depression and mood variability. But again, we really want to continue to rule out bipolar II disorder and focus more on current symptoms consistent with major depression. Leaving it in the back of our mind to make sure through our assessment, which we'll talk about more in a little bit, and use of instruments to really make sure we're honing that diagnosis. Looking at the precipitating factors, our procedure for gaining this information would be explore the possibility of trauma contributing to current symptoms. Again, we really want to make sure we're trauma-informed and person-centered and asking about any possible history of trauma and whether or not that could be related to her current functioning. We'd want to assess the impact of these precipitating events on her current functioning, and again, did something in the present trigger past trauma? Or also, trauma isn't necessarily a singular event. It could also be the cumulative nature of stress. Of course, can be very traumatic. It has the same neurobiological impact, so we'd really want to know what role does stress play in her life. And our findings, we find out the breakup with the married studio owner certainly triggered the current depression. We also learned that related to the spending on his credit cards and things, he's unlikely to be a support in the near future, and that brings a lot of loss issues for Manuela. She's clearly grieving that loss and recognizes, again, the relationship between her relationship with this man and attachment issues with male figures in her life, that establishing trust and being able to have stable relationships has been a challenge for her. The loss of job is certainly a major consideration here as well, and her meaningful career and how she defined herself with dance and performing, and to have that not happening now really causes her to question her sense of self, so that's a very key indicator as well, something to be paid attention to. But through her sharing, Manuela lets us know that there's not going to be any legal charges pending from the use of the credit card. But she decides on her own that she wants to establish a plan to either return the items or pay off the debt. So no legal entanglements, but she certainly wants to move past what happened in the right ways and rectify that situation. More about perpetuating factors. What's keeping the symptoms going? We'd want to assess for the potential impact of any current medical conditions. Again, important to mention. What are the current environmental stressors, relationships, losses, etc.? And what we find is there's a real need for stable, dependable social supports in her life, that she doesn't identify having close friends, and her relationships come and go, are rather fleeting, and she kind of identifies herself as attaching strongly to people and then losing these relationships and feeling adrift. Also, related to the employment, she wants to return to work in some capacity, but really recognizes the need to do things differently and to look for work that is less emotionally draining, or how to manage the same work in a more stable and predictable manner. The protective factors, the positive factors, very important to look for and include in our analysis and formulation as we're preparing for the treatment planning process. Procedurally, we want to assess for potential contributions from both her natural and professional supports, medical professionals, etc., and look at her attachment history and how that relates to her current relationships. We develop attachment bonds early on, or attachment patterns, I should say, early on, and those play themselves out in our lives. We want to make sure to pay attention to that, especially relative to her relationship with the studio owner. Findings, she's agreed to involve her brother in treatment in the near future. So through our discussion around stable supports and his desire to be supportive of her recovery here, she's agreed to get him involved in treatment. And again, of course, in a person-centered way, she leads that charge. We work for her in defining when her brother can be involved in treatment. But getting those key collaterals, those people that care to help us help these clients, is an extremely important next step. We learned that she's not been abusing alcohol, and she's willing to discontinue her use of alcohol and has discontinued the use, and she's willing to bring in the over-the-counter pain medications. So hopefully that will mitigate the risk, and she won't be gathering more pain medications, and it speaks to her trust of the service providers that she's going to give up those pain medications and any plan to use them if things got extremely difficult, even more difficult for her. We note also a protective factor. She has a positive work history. She has a job she loved. She was a hard worker, gave herself completely to that job, and whether she returns to the same field or applying that same work ethic to a different field, that's a very positive factor that she can attain work and the stability and the self-esteem enhancement and all those positive things we get from work, that she's looking at returning to that, and that can be nothing but a positive in her life. Let me just take a bit of an aside, and I think we'd want her to lead on that, but we wouldn't want to take too long. If she says she's ready to return to work in some capacity, I think what we've learned in recent years is we don't want to talk her out of the benefits of employment and keep her out of work if she states that she's ready to give it a try and get back to that structure and all those good things work brings to her life. She reports a desire to find out how things went so wrong and move past the emotional pain she is experiencing. So there's a desire to gain further insight and to act on that insight and to do things differently. So we see the motivation to change coming out of that statement. And she also wants to avoid painful emotions more than she wants to end her life. So as we have conversations about the risk, about the suicidal behaviors in gathering medications, in continuing that conversation, we learn more that it's more about avoiding the pain than ending her life. So we really want to focus with her on dealing with that pain, managing that pain, finding positive coping strategies, and helping her life be, as she would put it, less of a roller coaster and more stable in her future functioning. So you can see how we're bringing together the analysis and formulation, and at the very end, prior to our springboard into our recovery planning, we have this summary statement that Manuela agrees to participate in treatment and is scheduled for psychiatric evaluation to address the need for additional diagnostic clarity and to determine if psychotropic medication may be helpful. She shared that she wants to climb out of this hole I'm in, find out what went wrong, and why I always end up picking the wrong guys, and why my life is always such a roller coaster. Again, notice the deliberate use of quotes here so that we're really in a person-centered way capturing what Manuela says she wants to get out of treatment. We want to avoid a cookie-cutter approach and really, since this document belongs to her, it's her treatment record, we want to make sure that her personality and her recovery jumps off the pages. Now moving in, we have this, we've done our conceptualization, we've considered the 5 Ps in great detail, we've got a summary statement as a springboard into our recovery or treatment planning process. And we know that treatment targets the functional deficits to reduce or eliminate the impact of the diagnosis. This is the statement of medical necessity. Treatment is medically necessary because we have a diagnosis that we're going to continue to hone, and we have those barriers that are directly related to that are currently getting in Manuela's way, that we want and addressing those barriers is why we're getting paid for treatment. So our documentation needs to include treatment that has been ordered or prescribed by the appropriate individual. Credentials are critical. So depending on the regulations and the service that she's engaged in, let's say in this instance it's PROS, getting that treatment ordered and signed off by the appropriate individual is essential. This service should be generally accepted as effective for the mental illness or addiction being treated. So has this modality of treatment worked for people with similar presentations? We want to make sure that it does. That's a standard of medical necessity. We want to make sure that Manuela is willing to participate in treatment, that she's doing it voluntarily, and that she's motivated for treatment. The individual must be able to benefit from the services provided and that she's at the right level of care. So we make the determination related to the acuity and chronicity of symptoms that we're prescribing treatment in the right doses for her. So if she's in a PROS program, her individualized treatment plan would have her engaging in that program in a way that she helps co-author at a frequency that is mutually agreed is most beneficial to her. But again, she leads that charge and drives that bus. So there also, again, the motivation. There must be evidence of active client participation in treatment. All the more reason to use quotes and make sure every step of the way is treatment providing Manuela with what she wants, and is it addressing the needs that she's identified. Now further into treatment planning, we want to promote behavioral change between sessions. Change is all about active behavioral change. Insight is great, but it's when the behavior changes and things are done about it that the real work really starts. So as we talked about in the treatment plan adherence webinar, we have a specific formula for defining treatment plan objectives. And well-written objectives are really the engine of treatment that define those behaviors and what will change. The two, you can use either one, acronyms we like to use are SMART, simple, measurable, achievable, realistic, and time-limited, or RUMBA, realistic, understandable, measurable, behavioral, and achievable. Notice they're pretty interchangeable, those two acronyms, but it's good to have the guidance to use one or the other of those. Again, these objectives should be written with the client and then crossed off the list when achieved. This, in our conversations with both Manuela and managed care, shows that treatment is moving forward and that change is happening and things are happening that are different in Manuela's life as she moves toward recovery. Examples of goals that we could get from Manuela, again, using quotes. I want to climb out of this hole I'm in, find out what went wrong, why I always end up picking the wrong guys, and why my life is always such a roller coaster. Notice the use of quotes. So we have a use of quote, and then we have some clinical information that we gathered from our assessment that we also would like to include. We need to address the current risk of self, ensure Manuela's safety, gain diagnostic clarity, reduce the symptoms of depression that she's experiencing, help her stabilize her mood, and help her return to employment and her previous level of functioning. The objectives that would go along with that goal, for example, are Manuela will bring her over-the-counter pain medications to the clinic for disposal during her next therapy session. It is recommended that you make that an objective in treatment, not just talk about it, but write it down and cross it off the list when she brings it in. It really speaks to her safety. Within the next 2 weeks, Manuela will call her brother and ask him to attend a collateral therapy session. Over the next 3 months, Manuela will get up before 9 a.m. on 5 out of 7 days of the week and will put on clean clothes. There's nothing that helps break depression like actual concrete behavioral goals. And if Manuela started with 2 out of 7 days, wherever she thought she could start and be successful, let's make that very concrete. I know that reads like a very simple goal, but achieving that can break the logjam, help break the logjam of depression. Over the next 3 months, Manuela will use a calendar to record her daily mood on a scale from 1 to 10, with 10 is great and 1 is really depressed. So using very client-friendly language there, we're also getting an assessment of mood that speaks to assessing for bipolar disorder and the need to rule that out. The treatment planning interventions that go along with this, her therapist will utilize cognitive behavioral therapy in full-length individual and collateral family sessions scheduled 4 times a month over the next 3 months to assist Manuela in reducing the current symptoms of depression. These are examples of interventions you could use. Notice the use of an evidence-based practice as well. She will also enroll Manuela in intensive rehabilitation IR level of PROS services to obtain stability of functioning. The staff psychiatrist will complete a psychiatric evaluation and will prescribe medications as indicated. And also we can include family members in interventions. How will they support the process? Esteban, Manuela's brother, will attend sessions when invited and will call his sister at least 3 times a week. So we want to involve him, if possible, in the treatment planning process. Now, just to reiterate, these are examples of objectives and interventions. There are many paths treatment can take. These are just examples drawn from our analysis and formulation. Now, let's say she's in the PROS services. We have an authorization requirement for individualized recovery planning. We've completed the treatment plan. and we want to verify it with a managed care organization. The individualized recovery planning begins when the plan is approved, and it must be done within 60 days of the admission date, and providers may offer additional services and bill add-ons for clinical treatment, intensive IR services, or services, ongoing rehabilitation and supports. Prior authorization will ensure that individuals are not receiving duplicate services from other clinical or home and community-based service providers. So yes to prior authorization, that we'll get this prior authorization, but there's not a need for concurrent review. Additional considerations, now going back to the need to do a careful honing of the diagnosis to improve diagnostic clarity, it's helpful to use specific assessment instruments in the assessment process. The Mood Disorder Questionnaire, MDQ, would be helpful to assess for manic and hypomanic symptoms. So whether a qualified therapist does that or whether this is done as part of the psychiatric evaluation, as long as it's done as part of the assessment process, we have evidence-based tools being used to help us clarify our diagnosis. Very important, not only for our communication with managed care, but for Manuela to really get a clear understanding of what these evidence-based tools say about what she's in treatment for. We also have the Patient Health Questionnaire, the PHQ-9, would be helpful to assess for depressive symptoms. These same instruments can be used down the road to assess for change as well. It's important to carefully assess for the presence of substance use also, as this may contribute to mood disorders. And just an important point, it's important to ask about this not just once and to follow up with it. Due to shame or many other reasons, as we all know, people aren't always forthcoming about their use of substances. So following up with this and getting collateral input for the benefit of the client, not in any blaming or shaming way at all, but to really understand that when people are under such stress, they do self-medicate, and we want to make sure we get a sense of this, and we really want to make sure we're following up with that appropriately. So again, the use of collateral information in the diagnostic process can really help assessing overall how we can best help Manuela.
Okay, so I'm going to just wrap up a little bit here for us following that very thorough treatment plan. Now, as Dave mentioned, there is going to be a stage, especially if this is a PROS level case, where the communication with the MCOs has to happen in order to make sure that the treatment is appropriate. And so what follows on the next two slides here are some questions that managed care organizations may ask specifically about this case. They can obviously be extrapolated to many other cases. And again, these are the types of questions that we actually received from representatives from within actual managed care organizations. So these are straight from the horse's mouth, as it were, about what it is that they're looking for when you or your liaison is approaching them about a case. So first up would be very specifically individualized to Manuela. How will this treatment impact Manuela's needs? Why is this treatment necessary? Again, in terms of history, what else has been tried? And especially for these higher levels of care, why wasn't that sufficient? Why was that not successful for her? And here that may be, the issue about, well, she refused treatment at a lower level of service, and her symptoms have been increasing since then, and her functioning has decreased as she's lost her job and her relationship. And so those types of pieces of evidence may help you here describe why a lower level of care, for example, just an outpatient level of care, might be inappropriate for Manuela at this time to stabilize her functioning. Another very important piece that is set up very well in this treatment plan is what's going to be accomplished by this treatment. How does this particular treatment or this treatment plan fit into the bigger picture of Manuela's recovery? And I think that there's a lot of key pieces here that Dave outlined about making sure she has that natural support of her brother put into place, finding her employment that is meaningful to her so she can reduce her symptoms in that way. But individualizing those goals about what is treatment going to accomplish is important to managed care organizations because, again, just saying, well, we usually give 6 months for this type of case is not going to be sufficient anymore for managed care organizations. They're going to want to know why this treatment, what are you going to accomplish for this individual? Related to that is the issue of how are you going to know when you've reached that treatment goal, and I think Dave did a really good job of outlining exactly the numbers, the metrics, how you would measure. Everybody who looked at Manuela's case would know whether or not she reports getting up 2 days a week and getting dressed, or 3 days a week and getting dressed. Those are very concrete goals that any therapist, any UN liaison, any supervisor would be able to evaluate without the subjectivity of she says she's feeling better. So what are you looking for? How exactly are you going to monitor it? And again, those conversations about the goals and how you monitor it are important to have with Manuela so that she's in line with the symptom measures or the however else you're going to measure these goals.
And I just want to add, too, related to the goal Manuela stated and those specific measurable objectives, they're deliberately written to show where you would start with Manuela. But it's important to know, once those are checked off the list, then the next set of objectives is identified, and it's a finite set of objectives, deliberately very doable and achievable. What we don't want is treatment plans, recovery plans that don't change, because they tend to reflect clients that we don't think will change. So we really want to make sure they're succinct, behaviorally driven, and again, they get crossed off the list to add to that sense of accomplishment. But the objectives we wrote for Manuela, just to be really clear, are where we would start, but we would certainly continue down that path toward recovery and write new objectives once those are achieved.
A few other areas that an MCO may want to have you clarify when you're speaking to them about a case. What strengths and supports, so again, that strength-based language, what are the natural supports that Manuela has that will facilitate either discharge out of the service, transition to a lower level of care, and her eventual recovery. So here again are some of those conversations about her brother and getting her into meaningful employment and those types of features. There needs to be evidence that these goals are member-driven. So again, this is, as Dave mentioned, that making sure that there's a collaborative process. Manuela's quotes are in there so that it's clear that these are what she wants to work with. Another point that might be requested is evidence that Manuela is willing to participate in this treatment plan. Again, that willingness or that motivation is an important thing to document in these plans. The proposed time period, again, as I mentioned, just saying, well, we usually do 6 months for this treatment is no longer sufficient. So how long is this going to take? And again, I think that's pretty clear in Dave's objectives that we're going to do this for 3 months and see what happens, check in, and then have clinical justification for that. Finally, anticipating barriers to treatment success early in the process are important so that it's clear to say what's going to be in place to address those barriers if they can be easily identified beforehand. If anyone does have any questions or comments, please, again, feel free to chat. Before you head off, though, MCTAC is very important. It's very important to MCTAC that we know what we're doing that is working for you and how we can improve it. So I think if Morgan is ready, we're going to post up a quick poll question just to find out how you feel about this topic. So today we tried a new thing. The format of this applies to our new discussion, reviewing a case example. We want to know if it was helpful to you, so if you could please respond over on the right there. It's important to us to know that if you don't get enough out of this case example, then we would shift the format for the next couple that we're trying to do over the course of this series. So if you could please reply to that poll on the right. And then Dave, yeah.
We had a good question come in. The question made the point that the goal itself, where we used the quote from Manuela, is in itself not measurable. So would it meet regulatory standards? The mode of treatment plan writing, the book or a series of books, it's on the 2nd edition, is Adams and Greeter Treatment Planning for Person-Centered Practice. And there are many ways to write treatment plans, but the Adams and Greeter approach is to write goals using quotes and do them globally. But the measurability comes, because it's a very good point that there has to be measurability in the treatment plan, but not necessarily in the goal. The objectives are clearly measurable and achievable in the way that they're written. Also, we've recommended the use of the PHQ-9 and the other mood disorder instrument. So out of that, we would get a very quantifiable result using that in the assessment process. And with both of those instruments, there is clinically significant levels and levels that show when a client is subclinical, when they've recovered to a degree to which they're not considered disabled by the condition. They may have some symptoms of it, but again, the score is decreased enough so that, again, it's at subclinical levels. Those are the measures that we would use to communicate with the Joint Commission, regulatory bodies, managed care. So in addition to the achievability of the objectives, we would also want to use those standardized scoring instruments to have very clear and measurable discharge criteria set up according to the use of those measures. That's a very good question. Thank you.
Great, thank you. And then in your last couple of minutes, just a quick point of business for everyone. If you haven't yet responded to our poll, please do so we know whether this case example format is worth pursuing again at the next two applied learning discussions. Also, we are going to take a little break for the Thanksgiving holiday from this webinar series, so please don't miss our next webinar on December 1st at 12 o'clock. It's about clinical supervision in the world of UM, so how to support utilization management procedures from a supervision perspective. Again, that's December 1st, 12/1, from 12 to 1, so it's easy to remember. If you have any other questions or comments after this webinar, please feel free to email mctac.info@nyu.edu, and they will get those questions over to us or comments over to us. And finally, these slides are going to be posted on the MCTAC website as soon as possible, so please feel free to share them with others in your organization. We're hoping these are a training resource for you to take back, so please take a look, and thank you very much for your attention.